right, now welcome back. Let's talk about the topic of discussion today, and that is all about planning for pregnancy. And I know where the question that we're asking you today is, what determines the gender of the baby? But of course, there's a lot of discussion about gender and sex and the difference between the two. But of course, not to worry, because we'll be dissecting more on the same right here on the show. So be sure to stick around till the end of the show. But of course, at the same time, be sure to tweet us at NTV Kenya at Lubembe_Winnie. And we'll be looking at your feedback in just a moment in regards to the question of the day. And that is, what determines the gender of the baby? You will understand why we're asking you this question, because there's a lot of myths and a lot of misconceptions surrounding who or what determines the gender of the baby. And of course, in studio to help us with the discussion today is Dr. Kireki Omano, who's a gynecologist and fertility specialist, right here with me in Studio A. Good morning, and thank you very much for your time today. And of course, we'll be having Dr. Samson Misango, who's a urologist. He'll be joining us in just a moment. But also in Studio B, we have Ruth Omanga, who is a mom to 4 amazing babies. And of course, we'll hear her story in just a moment. Good morning, Ruth. It's good to see you today. All right. Now, let's start with you, Dr. Kireki, in terms of the whole aspect of pregnancy, right? I mean, when you talk about pregnancy, there's so many things that come to mind. A lot of people have so many things to say about pregnancy. But let's just understand the basics. Pregnancy, conception, all those things.
First of all, thank you very much for inviting me to the studio.
You're welcome.
So it's a pleasure to come here and talk about some of these topics, which affect a huge population of Kenya. And talking about pregnancy, maybe I'll take a little bit, take a step back, talk a little bit about infertility, because that's a huge problem, which affects about 20% of the Kenyan population. And most people don't want to talk about it, or they rarely talk about it because it's stigmatized. You can't have a baby, or you don't have a baby, then there's something wrong with you. Pengine umerogwa, you know, etc. Pengine mama mkwe alikufunga. You know, we have all these myths, which are not necessarily true. Infertility, as I said, affects about 20% of the Kenyan population. And actually, some researchers say that is a conservative estimate, that it could actually even be higher, which is paradoxical, because in this part of the world where we have the highest rates of, you know, deliveries, of pregnancies, we also have the highest rates of infertility. Whereas in other countries, in the so-called developed world, infertility affects about 8 to 9% of the population. The causes can be very many. They can start with the gentleman, you can also touch on the ladies, and sometimes it touches both the men and the women. And there is a small percentage, about maybe 4–5%, whereby we quote-unquote unknown reason. But as my former boss in the UK used to tell me, there is nothing like an unknown reason for infertility. It's only a patient who has not been properly worked up. And there are other reasons which are not commonly looked into, for example, the immune system. So that could be the reason for that. Now, coming back to, first of all, maybe something which the public may not know, is that about 40% of the reasons of infertility actually affect us men.
Wow.
About 40%. About 40%.
You know, it's interesting because a lot of the times when you talk about infertility, it's usually directly associated to the women.
Absolutely.
And a lot of stigma, you know, associated with the same.
Simply because women are the ones who bear the brunt, let me put it that way, of the work that has been done, you know, behind closed doors, as it were. If that abdomen is not growing, then the problem is with the woman, not with the man. While for men, it's like, well, mbele iko sawa, but it's not always the case. We have cases whereby they have tried, find a couple has been trying for X number of years, and then after the gentleman does the simple test, you know, doing a sperm test, you find actually the problem is on his side, whereby the lady is okay. Coming to conception and pregnancy, you know, it is something which, again, happens so often until we think that it's just something, utapata mimba,
like
you know, and get, whereas it is not that easy. The way God has created our bodies, we are, as the psalmist says, we are beautifully and wonderfully made. The fact that at your body, the woman's body has to be at a certain state, and everything has to work together in harmony, that the hormones have to be at a certain level, the lining of the womb has to be at a certain level, the egg has to be released at a certain time, particular time, and once ovulation has occurred and the egg has been released and intercourse happens and those sperms swim. By the way, it's a long distance for them to swim, and they swim and they get to the egg and they crowd around the egg. And then one of them, only one, will actually go in and drill a hole. It's actually drilling a hole because they use an acid. Drills a hole around the membrane of the egg, and then the head goes in, and that's it. Nothing else, no other sperm can also go in. I mean, it is just out of this world.
It is so interesting to think about it. I mean, and we might think that we know, but then again, listening to you explain it, it's just, this is just like a very interesting, you know, phenomenon. And I appreciate the fact that you said a lot of people think it's a very natural process. I mean, you have intercourse, you get pregnant, end of story. But it's not. It's not as easy as we think.
It is not that straightforward. Now, again, before conception, what we are trying to tell the public is that we should consider what is called preconception care. What does that mean, basically? Number one, we want to understand the history of this lady and of this gentleman. Do they have does she have regular periods? Does she have any diseases, you know, chronic diseases, for example? In the family, is everything okay? We want to prepare, even the World Health Organization actually is advocating for this, that the woman has to be at an optimal state in order to increase the chances of her actually having a healthy baby, a healthy pregnancy, and a healthy baby consequently. The journey of pregnancy is also another mystery. Because first of all, that egg is, you can't see it. And the sperm also is also invisible. And then all of a sudden, these two elements come together and they create an embryo. And out of that embryo, it carries all the characteristics that this baby is going to have. The height, you know, the nose, the shape of the nose, you know, the lips, and so on and so forth. And then apart from the intelligence and so on and so on, it's just absolutely amazing.
It is incredible. It is incredible to just think about it and then to listen to you say it's just amazing. All right, now let's listen to Ruth for a moment here as far as her story is concerned. Like I said, she has 4 amazing babies, but how they came about is just amazing to hear. So Ruth, take us through before you know, your journey towards, let's say, pregnancy, and, you know, during a pregnancy and even after you delivered your baby. Let's just talk about before. Were you planning to have a baby? How was this journey for you?
Okay, good morning, and thank you for inviting me to the studio.
You're welcome.
Being my first time, let me hope I'll not have that phobia.
No, but you look beautiful. You're amazing.
Thank you.
You're
Thank you.
Thank you. All right, go on.
So I got married in 2012, and by that time, when you get married, you're so young, if I can say so, and you just think like getting married. You just get married and then you just stay, and then babies just come. You
have a baby, which is like a common African thing.
Yeah, you don't have anything in your mind.
Like, when is the baby coming?
Yeah, when is the baby? And you think it's an obvious thing. So when you got married, in fact, I conceived in 2013, around October. And then barely 2 months, I miscarried.
I'm sorry.
And after that, it was a shock to us as a family, together with my husband. And we had lost my mom. So I thought, like, maybe it could be out of the pressure or out of the stress of losing our parent. But we just said it will be okay as time goes by. And when we went back to the road again, we had to, like, it's going to happen anytime. Unfortunately, it didn't. 1 year, 2 years, 3 years, there's nothing. And then you ask yourselves, what could be the problem? Maybe you are asking each other, God will open a way. Maybe there's a reason as to why it's delaying. Everything is going to happen at its own time. So one day we just said, let's go and see a doctor. Why should we just assume like everything is normal? And yet there is no baby coming. And you know, the stigma and the people who see you get married, they expect a baby tomorrow.
Oh, absolutely. Yes.
And you're like, you as a couple, you have your own plans. Maybe I'm not planning to get a baby in 2 years, 3 years. I can even wait for 5 years. But that stigma and that mentality of people telling you, maybe, what are you waiting for? They don't even know that you have gone through a miscarriage, which you may not share with everybody. But
yes, I can hear you.
You just keep it, and you say, let's just go back to the doctor and see what they have to say. So you went to see the doctor, and the doctor advised us to go and have a complete hormonal profiling, and my husband has to go through the semen analysis, so that, because he said this thing has to be a combined thing. We don't know who is who. Yeah. Like the doctor said, it could be a man thing, it could be a lady's thing. Yeah. So we went together and we did everything. So after doing everything, it was a shock on me that my hormones were off completely.
Oh, wow.
And after I miscarried, I was, the doctor said, your breasts have milk. Oh. So he gave me a medicine, I think it was, is it bromo something? Maybe the doctor could be knowing the name, bromocriptine. Yes. Yes. And he said that one is going to lower the levels of the milk, so it will dry.
Okay.
And then after that, now, the hormones, when the results came, there is this one hormone, prolactin, which was so high. And the doctor said, now your body has been behaving like it's pregnant.
You're pregnant. Yeah.
So you're always pregnant, so there's nothing taking place. So the ovaries, everything knows you're pregnant. So the release of the egg, the ovulation is not there. We are waiting for the baby.
Okay. Can we pause it there for a sec so that we get to understand, right? That, of course, also involve Dr. Kireki for the same. Yes. We understand we have Dr. Samson Misango with us in Studio B. Dr. Misango, it's good to have you with us. Thank you very much for making time. Very quickly, and I'm pretty sure you got a bit of Ruth's story, but before you came in, Dr. Kireki was talking, just helping us understand how cases of infertility, and especially between men and women, is, and how most of the time it's the women who are being blamed for the same, but also we've heard that, again, 40% of these cases are among the men. So, and also Ruth talking about the test that she had to undergo, and her husband as well, that she had to undergo. First of all, before we even talk about the checks and, especially when one is planning for pregnancy, let's just talk about the men in general in terms of the checkup that probably the men has to go through or have to go through, and why is it so important for them to just make sure that they are healthy? Like Dr. said, mbele.
Yeah, good morning, viewers. Sorry I came in late, but I've just been able to pick up from the conversation that you've been having about infertility. As explained by my colleague, Dr. Kireti, the issue of male infertility contributing to inability for couples to have children is one of those things which is completely understated in the country. And more so, in our culture as Africans, a man is considered not complete until he's firing well. And most of the men, we actually avoid bringing up that discussion on the table about their potency or lack of. So what we normally do a lot of times is we let our women go through the process of checking whether they are fertile or not. And the man most of the time just hangs around. And the ones who have the, should we say, the guts to come to my office as a urologist will somehow be expected to do one simple test. And that's why you say in infertility, the test actually begins with the man. because we have a very simple test that is done for the man to check whether he is able to produce fertile, or rather whether he's fertile or not, and we call that a semen analysis. So it's a simple test that is done in most laboratories in the country, and we look at what is called the quality of the sperms, quality and quantity. And so most of the time this basically involves the man having to masturbate, because that's the simplest way of getting a specimen. And then we look at the number of sperms that he has, the quality of the sperms, and generally we look at whether it's possible now for those sperms to be deposited in the woman for conception to occur. Okay. So it's a simple test that is done, and most of the time it will be able to find to let us know whether there are issues with the man that make it not possible for him to conceive, I mean to fertilize or not. Okay. So as we go on, I'll be able to explain some of the things which will make the sperm's qualities maybe not good or
yeah,
not.
absolutely.
Yes.
We'll just go through them one by one so that we make it very clear for everybody who's watching us, you know, just to understand how important these two people, that is the man and the woman, coming together to make sure that they have a healthy baby. It's not only like a woman thing. But I'm also curious to find out, how often do you see the men? Like, how often do these men come to your office to seek for these services? Because when you talked about the aspect of how you will be able to get the sperm to conduct the tests, most men, like when you talk about that, they're like absolutely positively, no, thank you very much, I'm not going. So I'm just curious to find out, how often do you see men who come seek for these services?
Well, as a urologist, I think it's fairly common, but when I was a younger doctor, it was very difficult to see men come into my office. You see, practicing in Nairobi, I get a lot of patients who have been referred to my office by a gynecologist. Usually it will be a gynecologist who has referred a man to my office to get assessed for possibility of infertility, and a lot of times they'll have had a test done at the office of the gynecologist, because, as I said, in our African culture, inability to have children is always blamed on the woman until proved otherwise. So they will go through a lot of tests in the gynecologist's office, and eventually the man will present himself, and there's something that the gynecologist will pick out and refer the patient to me. So it's, I can say maybe on a daily basis, I will see maybe 1 or 2 people that will have that kind of a problem, and then I address it according to the cause. Okay. So it's not that uncommon these days, but they are referred. It's very rare that you find somebody walking into my office specifically wanting to have a semen test done to prove whether they're fertile or not. All
right. But certainly we need to see more of the same, you know. It's a good thing at least that they go, right, as compared to not completely go at all. Now, Dr. Kireki, back to you, and listening to Ruth's story, right, where 2013 she conceived, but unfortunately had a miscarriage, and we're so sorry for that, Ruth. And then took a while before she conceived, and of course we'll talk about that process later. You know, and all these tests that were done, you know, hormonal profile, prolactin, it was like a lot of terminologies. Help us understand, because I'm pretty sure there's so many women who probably are dealing with the same, and they might not know. Like, for instance, Ruth did not know until she went to the hospital.
First of all, Paul, I stand a Ruth for losing a baby, because losing a baby is something that is tragic.
Traumatic, yes.
Whether a patient loses a baby at 6 weeks or at 40 weeks, it is the same. Emotionally, it's devastating for these patients. Now, unfortunately, about 40, even up to 50% of the pregnancies that occur actually do end up in a miscarriage. And the reasons for the miscarriage are very, very many. You can start with the embryo itself not being proper, meaning that it can have some what you call chromosomal issues. There can be issues with the patient herself. She has, for example, chronic diseases like high blood pressure. Diabetes is a very big problem, because that extra sugar is actually toxic to the baby, and it actually kills them. And I've seen patients who have got pregnant, you know, 3 times, 4 times, 5 times, and they've lost babies, you know, at almost the same time. And nobody ever sort of took a step back and say, can we check the sugar and let's see what is happening? And once they check the sugar, they find, my goodness, this patient is actually diabetic, and the sugar levels are so high such that it is not possible for her to actually carry a baby. So once they are sorted out, she actually has a chance of doing that. Infections can be urinary tract infections, you know, general infections of other systems can also lead to that. We have what we call autoimmune diseases. For example, rheumatoid arthritis and so on can also lead to that. Diseases of the thyroid. She mentioned hormonal issues. And here hormones, for example, we have thyroid stimulating hormone. The thyroid gland, which sits just in front of the voice box, is a tiny gland which is about 70 grams, but very, very important because it sort of, quote unquote, it manages how the body behaves. So if the hormone levels, the thyroid stimulating hormones are elevated or they are low, it actually affects the way the body behaves and obviously the reproductive system. Talk about the hormone levels. She talked about a very elevated prolactin levels. What prolactin does is basically the body, as I said, is we are beautifully and wonderfully made. God has created us in such a way that when a woman is pregnant, already the body starts getting ready for that baby, such that there's provision for it. The baby will have food and enough food and obviously nutritious food, which is the baby's milk. Now, this is only possible because of the prolactin hormone. The prolactin is produced by the part of the brain, and it tells the breasts that, you know, so-and-so you are pregnant now, we have to start preparing. Now, when prolactin is elevated, unfortunately, the body thinks that it is pregnant. So don't get pregnant. You can't get pregnant when you're pregnant. So all these things need to be taken into account. Like she said, they went and her hormones were completely off. And we have to start sorting them out slowly. And some of them actually just requires a blood test. And once we get the results, we give them medications, and the hormone levels are where they are supposed to be, and hey, presto, they get pregnant. But again, it's not always that straightforward. There can be other issues as well. There can be blocked tubes, for example. There can be what Dr. Misango talked about. There can be issues with the sperm. The sperms may not be enough. They may not be swimming. Again, you remember we talked about swimming. They may not be swimming the way they are supposed to swim. We may also not have the number of sperms which are okay, what we call morphology. You know, we talk about, it's actually a small number. It's about 4%. We just want 4%. So, for example, if a man produces 100 million sperms in what you call the total count, we only need 4% or more of this to be okay in order for him to be able to help his partner to conceive. And 4% out of 100 million, 10% would be 10 million. So 1% would be a million. It's about 4 million. And by the way, remember, we only need what?
Just what? Exactly the question I want to ask Dr. Misango in terms of, I mean, and I'm pretty sure both you and Dr. Misango have had this, where people say, but we only need one. Why do we need like all this big numbers? So Dr. Misango, why do we need these things in millions and millions? But yet we only need one. One lucky
There's
one.
a lot of wastage going on, by the way.
Exactly.
I'll put it this way. During our evolution as a species, as a human being, it is said, this is basically what we know from evolution. Once upon a time, we lived in the sea. And we migrated from the sea to the land in search of resources. And the way human beings were designed is just like other animals in the sea. You basically give out your sperms into the ocean, and then the strongest one survives to get to the target. And for you to be able to have a chance of having conception occurring, the more sperms you produce, the better, because one of them will reach where it's supposed to reach. You have no idea where. Now, so now that we are where we are as human beings, and we have a relationship between a man and a woman, the same theory still holds, because the environment of the woman is not always conducive for fertilization. So the more sperms which are produced, the better, at least one of them will be able to achieve its objective. And what we also talk about, the survival of the species and the strongest survive, is such that the one that will make it to achieve the objective will be the strongest of the ones that have been produced. So it's still a very wasteful process, because as Dr. Kireti explained, we basically, in that one spoonful that is produced of a semen, there will be nearly 200 to 400 million, okay, sperms. And it's basically like a marathon. There are so many people who start, but only one will be able to reach the finish line. Huh? And once the person reaches the finish line, nobody remembers who was second or third or fourth. It's only the number one. So that's the same theory that applies to most mammals. Huh? So it's a wasteful process, but it's what it is that we have. Huh? And that is why we are advised as men to ensure that you keep as healthy a body as possible to ensure that you produce healthy sperms.
Okay.
Yes.
All right, and how do they do this? You know, and especially when it comes to, let's say, like infections, what are some of these factors that might affect the quality of the sperm that will make it possible, you know, to fertilize an egg and eventually have a baby?
Now, there are many... Sorry, I'm getting some interference on my phone.
It's disconnecting.
Are we okay?
Yes, yes, we're okay.
Right. First, there are many factors that can interfere with the quality and quantity of the sperms. Number one, you can have what we call congenital conditions, things that you are born with that make it not possible for you to produce good quality sperms. And this, because sperms are produced in the testes of a man. The two, what you call, I think we're all aware of the term testes, the testicles that basically hang between a man's legs. So when a man is born as a child, when a male child is born, there are some particular organs which are geared towards producing sperms, and they have to develop outside of the body, hanging down, for optimal blood to flow, for an optimum environment for them to produce the sperms. Now, there are some boys who are born with what we call undescended testes, so that the testes are actually in the abdomen, and that environment makes it very difficult for good sperms to be basically to be produced by the cells in the testes that produce the sperms. So it's one of the commonest conditions that we see a lot of children who are born as boys, but they have problems with sperm production because the testes are developing in an abnormal environment. Now, apart from these congenital conditions, we normally have now the acquired conditions, which some of them could be infections, some of them could be accidents, some of them could be diseases that develop within the testes, because it has to be a disease or a condition that affects the testes where the sperms are being produced. Now, so in adolescent, we talk about a condition that can result in the testes twisting on its own blood supply, and thereby interfering with the production of the of the semen, of the sperms. Remember, in life, we rely on blood to produce the necessary. Sorry, I'm getting a lot. Sorry, there was some disruptive noise I was getting in my earphones, but it's okay. Okay. Now, in life, we rely on blood to supply the necessary nutrients for proper development of any cells. So during adolescence, as a man's testes is now getting mature, to be able to continuously produce the sperms, there could be an incident that basically results in the testis twisting. And when it twists inside, this blood supply from the body is disrupted. When that happens, we have what we call torsion, and that actually destroys the testis, which has been affected. Now, nature or God has given us two organs. One of them is a spare of the other one. So with one testis, you can be able to perform pretty well as a man. But of course, there'll be always that, what you call a stigma that's attached to a man who has one testis. And so we have other procedures which we do to give somebody a simulated, basically an appearance of having a normal testis. Then, as somebody keeps on growing and gets sexually active, then we have sexually transmitted diseases which somebody can get And some of them would be coming from actually sexual diseases. Others would be diseases which are in the blood. Sorry?
All right. There's a bit of still. Are you still facing interruptions? All right. Let's sort that out. Let's talk to Dr. Ruth. Are you feeling the same interruption so that we can sort both of them? All right, Dr. Kireki, let's talk to you. You know, as far as what we talked about earlier on, and that is on preconception care. Yes. And I like the fact that we're pointing all those things out just to make, let's say, the people understand how important it is to just go and get checked, especially when you're planning to have a baby. That's right. And we understand some of these tests that need to be done on the men, but then probably the women are watching us and thinking, but what about us? What are some of the tests that are done for us just to make sure that everything is okay? You touched on them a little bit earlier on, but just to make it more clear for people, just in case someone missed that part.
Absolutely.
Yeah.
Now, actually, these are some of the questions that people ask. I am in a relationship, and we are serious in this relationship. We have gone to church. We have done the premarital counseling. Yeah. Is there something that we can do such that it can sort of increase our chances of getting pregnant? Yes, there are some things that we can do. Number one, we start by being healthy, eating nutritiously. Dr. Misango talked about men being healthy, doing things which are healthy in order to increase the chances of producing healthy sperm. So eating healthy, doing exercise, very, very important, but we take some of these things for granted. Remember, we have changed the way our grandparents used to live and the way we are living now. They used to eat fresh foods from the garden. Yes. Cooked very well, even though there was not maybe very little oil, very little salt. But we see that most of them grew to the 80s, sometimes even to the 90s and so on. They used to do a lot of manual work. So that exercise came without even them thinking about it. That is why we see our great-grandparents had, great-grandmothers had 11 children, 13 children, 15 children. Yes. Obviously, they did start getting these children a lot earlier, and then they got them every so often. So a healthy lifestyle is important. Okay. Number two, to visit your gynecologist, such that you may, as I said, we walk through the medical, surgical history of this patient. And also, we also need to talk to the husband as well. Some of these issues that Dr. Misango talked about can actually be highlighted and caught very early. For the man, it's a very simple test, a semen test, a sperm test. Abstinence of 3 to 5 days is required, and then they go and give a sample. Now, the issue of men coming to be checked, it's very rare, by the way. And I have a clinic 2-3 times a week. For a man to come himself,
it's very difficult.
Very difficult.
Like Dr. Misango said, unless they are referred.
Unless they are referred. Even when they are referred, they come very reluctantly. Yes. Now, even when they come with their spouses, they also come, it's as if they've been pulled there, screaming and trying to not to come, and they come and sit in a corner and they look at you. It's like, what am I doing here? So a sperm test is important. Now, once we have done that sperm test, remember the parameters that we talked about. Talked about the volume, we look at the count, look at the concentration, the motility, and the normal forms, and so on. So we can actually be able to identify some of these problems quite early, even before now they start thinking about having a baby. Now, for the lady, for the ladies also, once we've taken the history, the medical history and so on, there are 2 or 3 tests which we need to do. The first one is to check their tubes, whether they are okay. Because remember, once that egg has been released by the ovary, it has to be collected by the tube. And then tube is just a tube, but at the end of the tube there is what we call fimbriae, and they actually grab the egg and pull it into the tube, such that by the time this lady is going to have intercourse with her partner, the sperms will swim, and actually they will meet at a particular point in the tube. It is not just anywhere. It is not random.
It has to be
at a particular point. Yes, at a particular point. Now, we need to check whether these tubes are okay, they are patent, such that we know that if these sperm are to pass through, then they will be able to get to where the egg is. There are very many issues which come up. You may find that the tube, one of the tubes is blocked, the other one is okay. You may find both of them are blocked, and there are different levels or different places where they can be blocked. Sometimes the tubes can have fluid in them, which is also a problem, and so on. So we need to check the tubes.
Okay, can we take a call? We have a call on the line, and then we'll come back and continue with the discussion. Good morning. Hello, good morning.
Yes.
Hi, how are you this morning?
Fine, thank you.
Thank you very much for calling us. Do you have a question or do you have a comment?
I have a question for the doctor.
All right, go ahead. Marion?
Okay.
Kindly turn down the volume of your TV so that we can communicate very well.
Yeah, I can see on the screen, like they are not answering. Hello?
All right, go ahead.
Yes, yes. I have a question to Dr. Kireki.
All right, go on.
The Kireki, now that you have seen this only one sperm that fertilizes an egg.
Yes.
How comes that there are women who get babies, more than one baby in the stomach, and we have only biologically the babies are fed through the umbilical cord. How does those babies we see in the television that they are 3, they are 4, they are 5? How do they get to the umbilical?
All right. Thank you very much, Marion, for that question.
One umbilical cord.
Okay.
All right. Thank you very much, Marion, for that question. Of course, that is
I'm a community health
story.
volunteer, so thank you, my seniors.
All right. Okay. So that is actually Ruth's story, and we'll hear that in just a moment. She had triplets. Okay, so we'll hear that in just a moment, but very quickly, Dr. Kireki, or before you answer that, can we take a break, and of course, so that when we come back, we'll hear Ruth's story, and then you'll also be able to tie them, and also answer Marion. But keep calling or tweeting at NTV Kenya at Lubembe_Winnie, and of course, we'll be looking at your feedback after this very short break. Stay with us. All right, welcome back. Glad you're still with us. Remember, the show is Your World, and today we're focusing on planning for pregnancy. Of course, we're asking you what determines the gender of the baby. Of course, we'll be answering that question in a few minutes because there's a lot of discussion about sex, gender. What is the difference between the two? Is it one and the same? Is it different? But of course, we'll be getting a better understanding of the same in just a moment. But keep tweeting at NTV Kenya at Lubembe_Winnie. Remember, the hashtag is new normal, and tell us what you feel about the question of the day, and that is what determines the gender of the baby. Or if you have any other question in relation to the topic of discussion today, feel free to give us a call. And of course, we have experts right here in studio who'll be able to answer your questions. But for now, let's talk to Ruth about her story. So of course, she conceived in 2013, had a miscarriage, which is sad, and we empathize with her. But eventually, after a long period of time, she was able to conceive. So Ruth, after the treatments, that you and your husband both had to go through some of these tests just to understand what is going on, and you talked about an aspect of elevated hormone and prolactin. How long were you on medication, and eventually when did you conceive?
Immediately after the tests were done, the doctor told us that the first hormone to work on was prolactin, which was too high. So he gave us medication first to go and try that and lower, then come back for another test to see that the hormones have gone down. So he gave me some medications which were so expensive. I think one was going for 600, one tablet, and I was supposed to take for a month.
Oh, wow.
1 month. So that's 600 times 30 days.
That's a lot.
And then after that, you are not sure whether it will lower. You go back again, you do the tests to see whether they have gone down. And now we went and bought the medicine, and I started taking. Hey, the medicines were so strong. You take them and then you feel like, I don't know.
Yeah.
You're sick. It's like now you're pregnant.
The morning sickness.
Yes.
Yeah.
That nausea and everything. I don't know what was the name, but it was I didn't want to imagine taking another one. So after that, I think he told us, because the hormones have started lowering, we can't just wait, because now that we have waited for, like, now it's a 3rd year now, we don't want to take chances. Like the doctor has just said, sometimes you might think that this lowering of prolactin will make you pregnant immediately. It's not always the case.
Okay.
So he told us maybe you have to take some fertility, what we call it, treatment, is it medications, like the clomid, something, which you have to take together with this, so that at least we see how to work out this.
Yeah.
Because also time is of essence, and also we never know. Some people might think it's now, but you'll take a longer period and you don't want to wait. So he gave us some medication, which I took. And then it was a tall order in terms of finances. And also that anxiety of when you take the medicine, you are waiting every month, because my periods were very regular. And my system was okay. So it was that thing we were waiting for. So anxiety, and then somebody tells you, don't be too anxious, it may not even happen.
Yes.
Relax, but you know,
it's so easy to say. So
easy to say,
just
and
relax. It
and
will happen.
The society is also looking at you. And you know, you go to church, you go to work, everywhere you meet people, and these people are talking about something.
Yeah.
And now you also ask, 4 years is not a long period. People have stayed for 10, 15. You know, you also have to sit down as a couple and encourage one another. So in the process, I conceived in 2017. In fact, it was a shock because I didn't expect.
Yeah.
And immediately it happened. I was like, let's go to confirm that there is a baby.
Pregnant. Yeah.
So you went, and then the doctor said, it's too early. You sometimes you might, I don't know, but he said a scan can show.
That you're
even,
pregnant.
Whether you're, even after 2 weeks, it can tell that there is something inside. So when I missed my period, I was like, this has happened.
Yeah.
And now with the previous miscarriage, I was so scared. But we went for the scan. I was alone. I think my husband went to work. He dropped me there. And the nurse, the one who was carrying out the ultrasound, told me, now just relax. I'll just tell you what I'll see. Then she started doing the scan. She does, and then she says, I don't know what I'm seeing.
Okay.
She continues scanning.
Yeah.
Then I'm like, what? I'll tell you. I'll tell you exactly what I'm seeing. Yeah. What I'll see is what I'll tell you.
Okay.
Then she tells me it's like there is more than one baby. Okay, let's start. She gets the heartbeat of the first one.
Yeah.
Then I close my eyes. I'm like, okay. The next one, she goes, tells me there's another. Then, you're expecting 3.
Wow.
I was like, it was a shock. At the same time, a lot of fear.
Yeah.
Because of the uncertainties. Immediately, I told my husband, and then we said, now we have to go back to the doctor and tell him
that you're expecting triplets.
Going back to the doctor, it was not easy because the feedback was, being a multiple pregnancy, it's not going to be easy. Anything can happen.
Yeah.
Twins is better, but with the triplets. We have to pray harder.
Yeah. Okay, let's put a pause over there. And I think this probably, if Marion is still watching, I'm sure she's like, okay, now this is what is happening here. We only need 1 sperm, but then, I mean, like Ruth, she has triplets.
That is true.
Yeah.
That is true. Now, maybe if I can touch on one or two things before I comment on Ruth's experience. The issue of preparation, the issue of what to do for the ladies. We had talked about having a test to check whether the tubes are okay. A hormone test is also very important. You remember we talked about how prolactin level is very high. So we need to do a hormone test. And then lastly, we need to do a scan, a transvaginal scan, which basically will help us to look at the ovaries to see whether everything is okay. And also to look at the womb itself, because remember, the baby actually implants in what we call the endometrium, or the lining of the womb. So sometimes there can be, the lining of the womb may not be okay, so that can also be a reason for this lady not getting pregnant. Coming back now to the question of Marion from Meru, and then I think I'll try and tie it with what Ruth has talked about. Obviously, yes, according the way our bodies have been created, we are supposed to have one baby, carry one baby. But then there are some times whereby the woman's body releases an extra egg, or extra eggs for that matter, what you call hyperfecundity, meaning that in that instance, in that ovulation period, she produced 2 eggs. And because of the semen sample, which is very good, they end up fertilizing both eggs at the same time. And here's what we end up, woman carrying twins. And by the way, it also related to the food that we eat. We do know that the Yoruba ethnic group in Nigeria has the highest percentage of twins, of multiples, because it has been attributed to the food that they eat, and this food actually has an impact on the center in the brain which releases what we call GnRH, that is gonadotropins, and these are the ones which actually release the female hormones, which act on the ovaries in order for them to produce eggs. So the food is also important. Whereas naturally, as I said, you can only carry one baby. There are instances, like in Ruth's case, whereby she ended up carrying 3 babies, meaning she was hyperfecund. And number 2, her husband's sperm was extremely good. So I think maybe they can put something on the wall. You know,
right?
And now the other instance. Now, naturally, for a woman to get pregnant and carry triplets is extremely rare. It's about 1 in 3 million deliveries, which is very rare. However, with the IVF that we do, in vitro fertilization, of helping these women who have issues, or these couples who have issues, the chances of carrying triplets is about 16% relative to the general population. In my practice so far, I think in the last 4 or 5 years, I've had about 10 triplets. Which is unprecedented. You know, naturally it would not be possible. But because of that, why does it happen? Because we transfer 3 embryos. And if you are lucky that all 3 embryos implant, then you'll be carrying triplets. It has its own problems because, as I said, the womb is designed to carry 1 baby. When there are 2, we want them to go to around 36, 37 weeks. When there are 3, we really pray that we get to 35 weeks. And if we can't get to 35 weeks, then we have to be really prepared for this. So yes, it is possible to actually carry more than 1 baby, but it is difficult. Now, the other thing which I may want to mention here is about twinning. So if in the family, hereditary, you find where there are twins in the family, the chances of a lady having twins, or a couple having twins, is also very high. And again, this happens because there can be what we call similar twins, and the other ones which are not similar. Meaning that when you have 2 twins of the same sex, most probably there is what you call splitting. So one egg got fertilized, but then because of the genetics which are involved, they split, and then you have twins who resemble each other, and then they are of the same sex. However, you can have twins which are different sexes, meaning that 2 different eggs were and were fertilized at the same
All
time.
right. Yeah. Dr. Misango, I'm curious to know if you'd want to chime in, and especially for Marion's question, where only one sperm, but then people have like triplets and twins and all those things. And then also tie that with the question of, is there any chance that the lucky one, you know, the lucky sperm, could, again, maybe have like a bit of defect, but it still managed to get through? Is there such you know, chances?
Yes. Before I answer that, maybe let me just finish. There's something I was talking about.
Oh, yes.
The possible causes why a man would have issues with the sperms. And I'd say you can have infections which are in the blood, like TB, for instance, that basically goes and attacks the testes and makes the testes' ability to produce sperms be defective. You can have growths occurring within the testes, like tumors, cancers, that actually make it impossible for the testes to produce normal sperms. You can have accidents, and you see, we normally see footballers when they are lining up as a football is being kicked. They are very protective over their private parts, because when you have a sudden injury or a trauma or an accident that involves basically causes an injury to the testes, then obviously you'll have a problem with semen, with sperm production.
Okay.
Then the other issue that is normally very common, especially in our young people, is abnormal supply of blood, which could be there genetically, what we call varicocele, so that blood is not flowing well into the testes. And when this happens, it's something which most of the men will not even know until they go for a medical checkup. And when they're being examined, then they're told that they have an abnormal blood supply into and out of the testes, thereby interfering with the sperm quality. Then the other issue that we have to talk about is, you see, we talk about women as being hormonal, but we forget that men are also hormonal.
Yes.
And by the same hormones that make a woman be able to conceive properly, if those hormones now are in a man, they now make a man be unable to conceive, because they now disrupt the circuit. So it's basically a balance of things. So we also have hormonal imbalance in men, and it can be caused by other things in the brain, which are producing or interfering with the production of the hormones. It could be something with the thyroid, it could be something in the testes, or it could be something in the blood. Then we also have the diseases which basically interfere with the supply of blood into the testes. This will include diabetes, high blood pressure, any other systemic disease that somebody might be having can interfere with blood supply into the testes. So there are lots of problems that can actually cause a man to have a problem with production of sperms. Then, of course, we have to talk about the healthy living, because you say we are what we eat.
True.
So whatever it is, any chemical that you take from outside that your body has to struggle to deal with, then interferes with the amount of blood which is delivered or the food which is delivered into developing organs. Because as opposed to women, men are continually producing sperms every day of their lives, and those sperms have to come out at some point. So any small process that interferes with production of, or rather delivery of blood into the testes would interfere with the production of good sperms. Now, coming back to this topic of one sperm, one pregnancy, and how it happens that you might have multiple pregnancies. As Dr. Kireti said, you see, I said earlier on that we produce, men, not we, men produce a lot of sperms. Okay? And any of these ones can fertilize. And what happens is the strongest one, the most viable, the one which is most normal in appearance, let's say, is the one which is going to fertilize one egg. When that one happens, that process is blocked, but there could be a woman who is producing more eggs than one. So since we have over 1 million sperms, you can fertilize as many sperms, as many eggs as the woman is producing. Okay, that's one thing which you need to understand.
Oh wait, like just to make it clear, one sperm can fertilize as many eggs?
No.
That is what you're saying?
One ejaculation can fertilize as many eggs as they are available.
All right, okay.
So if a woman has produced more than one egg in that month, then it's possible that the sperms which the man is producing will fertilize the 2 different eggs or 3 different eggs. Then there's the issue of a fertilization occurring, and then that egg which has been fertilized, it undergoes a process where it basically divides, and now we have what we call twinning that has occurred, or triplets. Huh? So these triplets can occur, as Dr. Kireki said, from 1 egg, or it can be 2 different eggs with 2 different sperms, 3 different eggs, 3 different sperms.
All right.
Okay.
Okay.
But remember, there's an overabundant supply of sperms, but a limited supply of eggs.
Yes.
So that's basically how the process works.
Okay.
As opposed to other animals like rabbits, which can basically produce as many times as possible in a month. Because they could keep on producing the eggs at different times.
All right.
Yes.
Okay, let's take a look at the feedback, and then we still have a lot. And remember the question that we asked, and that is, what determines the gender of the baby? That is the question of the day. What determines the gender of the baby? So, of course, we'll be looking at that in just a moment. But for now, this one says biologically, it is the male chromosome, but spiritually, it is what? God himself, for it is written. All right. And then someone else says, this is Shiki says, it is written, he knew us before we were conceived in our mother's womb. So I believe it is God's work and plan. All right. And then someone else says, this is Musa Otitiro rather, says, just play your part and pray to God to answer your prayers regarding the gender you prefer. All other stories are theories. All right. And then Mamake Steph says, biologically, it's the male parent since he has both XY chromosome. Okay. And then someone else says, this is Esther Ndungu says, only God knew the baby before he or she was made in their mom's womb. All right. Someone else says chromosomal character from the male gender, that is XY chromosome. If a man donates X chromosome, then the girl will be sired. And then Ivacha Brenda says time of ovulation, days before ovulation date, the chances of conceiving a boy are high. After ovulation, chances of getting a baby girl increases. All right. And then we also have Grace Njenga who says, does having irregular menstrual cycle mean that you are infertile, and how long does a normal ovulation last? I think Dr. Kireki will answer that. And then we have Metrin Nasimiu who says, ni majuma mangapi kwa mwanamke mwenye mimba kubeba mtoto tumboni, na mbona mtoto haizi zaliwa na 36 weeks ambayo ni miezi 9. All right, Dr. Kireki, then another question for you. So 2 questions for you, Dr. Kireki.
No problem.
Could you answer them very briefly, and then we'll talk to Ruth.
Okay. I think the first question is about irregular periods and whether she's infertile. Yeah. We talk about infertility when you have regular intercourse 2 to 3 times a week. There is no contraception which is being used, and a period of 1 year has passed and there is no conception. Okay. This period is shortened if the age of the woman is more than 35 years. Why? Because we know that after 35 years, fertility actually starts dropping. Yeah. So in her case, the question about irregular periods, yes, irregular periods can be a reason for infertility because then the body is not in sync with itself and it may not produce the egg at the time when it is supposed to produce it. So yes, that can be a reason for infertility. Okay. The second question was about carrying the baby, miezi tisa, 36 weeks. I don't know where the 36 weeks, the miezi tisa came from, because normally a pregnancy is supposed to last 40 weeks. 40 weeks, yes. That is 10 months, as it were. Now, why can't she deliver at 36 weeks? There is something what we call premature delivery or prematurity. There are different stages. There is extreme prematurity, there is moderate prematurity, and mild prematurity. So at 36 weeks, if a woman delivered at 36 weeks, for whatever reason, whether it is medical reason or because the baby wants to come early and so on, what we are afraid of is that this baby, especially one organ, which is very, very important, the lungs of the baby may not be very well developed at that time. So the baby may have problems with breathing, and we have to give this baby a lot of oxygen. That oxygen, very high concentration of oxygen, can actually affect other organs as well. And then apart from that, these babies who are not born at term have, unfortunately, a high propensity of having infections and having other diseases altogether. That is why even if a woman comes who is pregnant, let's say, for example, her waters are broken and she's, let's say, 32 weeks, we want to try and conserve that pregnancy as far as possible. Every day in the womb is huge advantage to the baby. So that is why we don't want them to deliver 36. We want women to deliver at 37 weeks plus.
Right.
Again, we don't want them to deliver at 41, 42, 43.
Because there's some people who actually go beyond.
Because then that also raises other issues because of what we call placental insufficiency. Again, we go back to creation, the way we have been created. The body knows that 41 weeks, 40 weeks, 41 weeks, huyu mtoto atoke. And if the baby doesn't come out, then the body starts to shut down because the blood supply starts decreasing and the placenta is not working the way it should. So you may end up actually losing this baby. So we have that period. So 37 weeks is okay, 37 plus, but again, don't go beyond 41 weeks.
All right. Okay, Ruth, let's talk about your pregnancy journey. So here you are, find out that you have triplets, but then the doctor is like, hey, okay, so this one, we have to be very, very careful, right? So take us through your pregnancy journey. And did you deliver naturally or normal, like people usually say, or was it via CS? And then 5 months later, something really interesting happened.
Okay, after the pregnancy, after the scan, I was, like I said, I was too anxious. At the same time, I was so scared because of the past
miscarriage.
So we had to pray harder, like the doctor said. In fact, we really prayed over this pregnancy. And I thank God for my supportive husband, because in terms of finances, the treatments, he was there. And he was okay from the word go. Like, you are okay, there's nothing wrong with you. So it was me. Assume I could have not gotten a support system from him, then I think things could have not worked. Now the pregnancy is also another risk. So we have to work on it. So heavy work, lighter things were proposed to us. And at the same time, you are supposed to ensure that you don't, how do you call it? Because it's still early, you don't have to, this motorbike, nini, this shake. You have to be very cautious. So we were like, you're pregnant, yes, but the precautions are too, they're taking your psychological is being affected to some extent because of that. So we really prayed, and thank God my pregnancy was okay. I used to go to the doctor after every 2 weeks for a check.
Just to make sure everything is okay.
Yeah, to make sure everything is okay.
All right.
Thank God to the insurance company, because we didn't have to pay cash. And then I was like expecting anything to happen, but nothing happened. Nothing. In fact, I was just okay. The morning sickness, it was like 1 month and it was over. Everything, eating, going to work.
Pregnancy.
Yeah, it was a fine pregnancy until I was 31 weeks.
All right.
When I was 31 now, I was at work. And then after going to the washroom, you are going and then you expect maybe just a normal urine, but the urine was not, it was a lot. And I was like, this one is not normal. I called my husband and I told him there's something, I feel like this urine is a lot and it's like a leak. Now after that, he told me just take a taxi and go to Mpisha. I'll come there. So that's what I did. I went to Mpisha, and already the doctor had given us a hint that your pregnancy could not reach term. Maybe, maybe not. So take precautions by booking a hospital with a well-equipped facility for preterms. So that's exactly what we did. We went through all the hospitals, and because we didn't want to take chances, we had to select Mpisha, and we said, whatever comes, the first thing we want to see is let the babies be okay first. And then in terms of finances, expenses, those things will come back later. So we went, and because my file was already there, I was admitted. The first thing they checked was my cervix. And they said, your cervix is still intact. So the only thing we'll do is to admit you, but because the baby's lungs are not fully developed, we'll have to inject you. So they gave me like 4 injections, And then they told me, you are not going home, you're going to stay here under hospital bed rest. So I was in hospital doing nothing, just sleeping.
Yeah.
And then the leak went and it reduced. And I was like, can I go home? They said, you are not going home.
Yeah.
You are going to stay here.
Okay.
With the advice of my doctor, we had to stay at the hospital. And it took like close to 3 weeks, sleeping and eating.
Yeah.
But you see, also your mind is like the nurses were checking on me after every 30 minutes. It was just like, this is too much. And you see the scan, they have to look for 3 heartbeats. Every now and again, 3 heartbeats. You have to go for scan ultrasound to see whether they are okay, to find the legs, to see everything. Personally, I'm in Google looking for triplets, and causes. So it is not something which is so easy.
Yes.
It was too much.
Yeah.
I was like, I was a bit stressed, and I was anxious to see how the babies look like. Now, after 3 weeks, it was around 8 p.m., and then I felt like some back pain. My doctor had just seen me, and he told me, you are okay. So he left. And then I felt a sharp back pain. Immediately, lower abdominal pain. I called the nurse, just come. She came. I told her the pain is increasing. It was so fast.
Yeah.
It was like it came and it started.
Yeah.
I started crying. Now you help me. The first thing I told them, remove the babies.
Okay.
Remove these babies and ensure they're okay. So I started crying. My husband was there. He said, now what we do, we call back the doctor to come back and see what to do. Calling the doctor, he said he's already home. So because my case cannot wait, we have to go with the hospital doctor.
Okay.
So immediately, I was like taken to theater, and a doctor was called.
Okay, so you had to deliver the baby. Let's put a pause on that. We need to take a break, but of course, when we come back, we also need to understand how were the babies, were they, okay, and all those things. And then fast forward to 5 months later, where you conceived another baby. And of course, we'll also answer the question of what determines the gender of the baby. I'm pretty sure so many people are like, yeah, we really want to know, okay, given the myths and misconceptions surrounding the same. So let's take that break, but keep the feedback coming. We'll be looking at them after the break. Stay with us. All right, welcome back. We are in the last phase of the show. Time really flies. Still a lot to talk about, but let's try and see how much we can cover before we end the show. But the question that we're asking you today is, what determines the gender of the baby? Of course, our experts will be answering that. That is Dr. Kiriki and Dr. Misango will be answering that. But for now, Ruth, very quickly, because our time is not on our side. So you delivered, right? Went to theater, delivered, your babies were okay. Let's fast forward to 5 months later. You conceived another baby.
Yeah, so after delivery, they were in the ICU for the NICU for 45 days. And after that, we were left to go home. They were okay. They were given a clean bill of health. And once we reached home, I was so busy. You see, now you have triplets.
Yes.
The maternity leave has been taken by minus 45 days.
Yes.
So from the 90 days minus 45, you have half.
45, yes.
You need to look for a house girl who is going to take care of these kids, 3 of them, same age. And it was a challenge to us because we didn't have somebody to take care of the kids. So we had to look for a house girl, the normal ones, and they could come and go. So in the process, I think I became so busy, as in I was like, there's nothing, like you go to work, you come back, you are taking care of the kids, and then you forget that, you are still fertile, because my periods had come back, but they were not that consistent. They could come 2 days, then they are finished, another month skip. So I was like, it's okay.
Yeah.
I don't want to give it so much concentration. This baby's here, need my attention. So I was taken into that, and in the process, I just started feeling funny. I felt funny, and then I told a friend, I feel like vomiting. Yeah. And then she told me, you know, when you're pregnant, 9 months is a long period. Maybe you didn't deworm yourself. So we went to the shop. In fact, we went to the pharmacy and bought a BZ for deworming. Oh, wow. And I took them. I took them because I wanted to deworm. She told me that is iyo ni minyo.
Okay.
So after taking the BZ, still the vomiting, now it came with a lot of, like it's serious now. I could wake up, feel like vomiting. So I said, let me go back to the hospital, back to Mpisha again. And then they told me, we have to do, how are you feeling? Are you feeling headache? I told them I'm not feeling headache. I have nausea, which is really interfering with my daily activities. So they told me, we have to take a pregnancy test. I told them, how can you take a pregnancy? I've just given birth to triplets. Yes. I can't be pregnant. Then I just sat and waited. Yeah. And then she told me, are you ready? We take the blood. I told her, take. Then after that, I waited. After 2 hours, they called me in. And then the doctor asked, do you have babies? I told him, I have triplets. Yeah. And they are 6 months. Yeah. And then he told me, you're pregnant, and it's already 3 months.
Wow.
So the pregnancy, I'm going for a checkup when it's already 3 months.
Wow.
So the same day, I called my husband and told him, I'm going for a scan. They have to check whether the pregnancy is there. Yeah. The scan confirmed there's a pregnancy, and the first thing I told the doctor, tell me it's 1. And he said, yes, it's only 1.
He didn't want 3 more babies.
So after that, I think he told me, now we have to walk slowly because there's nothing you can do. Yeah. But we'll just be okay. Yeah. But be sure it's going to be a CS because the period between the first birth and the second one,
was
anything can happen. Short. So we had to wait like that until I gave birth at 38 weeks. Okay. And then the baby was there.
All right. Yeah. So, Dr. Kireki, very quickly, because our time. I wanted, the reason why I wanted Ruth to talk about it is that so that we can talk about the spacing. Yes. Because, again, this is one of the very important things that a lot of people, not a lot of people, everybody needs to consider when it comes to conception. So, very quickly, does the shorter duration make it maybe the pregnancy riskier or the baby in terms of premature babies or low birth weight, or what happens?
It can actually be so, because remember, these babies that ladies carry, they're actually quote-unquote parasites. They get everything from the mother. Yeah. So all the minerals, all of the elements, whatever they suck from them. So that is why it is important. Once a woman has got pregnant, first of all, we optimize her parameters, the blood test and levels and so on. If we see that there is a deficit somewhere, we supplement that by giving tablets and so on, eating nutritiously and so on. So now, once you have delivered, we actually suggest the first thing that we do before we discharge any patient from the hospital is we suggest that she considers family planning so that she can be able to space the babies. Not because we don't want her to conceive, no. We just want her to conceive at the right time.
All right.
She had 3 babies, so she needs time to bond with these babies, to, you know, to give them the most that she can before she gets another pregnancy. So coming back to your question, yes, it is extremely important. We normally advise 1.5, 2 years, you know, such that the baby can suckle enough, you can bond enough, and then your body also can recover from that pregnancy before you can get another pregnancy.
Yeah. Because we hear a lot of women who are like, me, I want to do this thing quick. So after every year, me, I want to have these babies, and then, you know, but like you said, 1.5 to 2 years is pretty much okay.
Yes.
All right. Dr. Misango, as far as the men and all the tests and how important it is to make sure that they are healthy, really, in general, so that they can produce healthy sperms, fertilize the egg, and then we have a healthy baby. But now there's also the question of then who determines the gender of the baby, right? A lot of people say it is the man. Okay. What do you have to say to the same?
It's this way. You see, men, we say in very simple terms, men carry 2 chromosomes. There's an X and a Y. Females carry an X chromosome, which is X and X. So in very simple biological terms, a person who is a female has 2 X's, and a male has an X and a Y in the sperms that are produced. Now, what determines the gender is whether somebody has a Y in their chromosome or not.
Okay. All right.
So we say the way we were created, or the way we develop as human beings, the default setting is to form a female unless a Y comes in to interfere. So as long as a Y is inside, then the direction of development of that baby in the womb is going to take the direction of a male.
Okay.
So that's why I normally say that the man is the determinant. But you remember, the female has to produce her, the excess in the woman makes the baby that is produced a complete woman. So if the female doesn't have any of the X chromosome in her, you'll have only the male chromosome, which is a Y, with a 0, which produces an abnormal male boy. If the male has an abnormal or an absent Y, there's no way this male can actually produce sperms that are healthy. So you need a man who is healthy with both X and Y
chromosomes,
and a female who is receptive with an X chromosome, so that the male can produce the X and the female's X's to combine to form a female child, or a normal Y chromosome from the male and the default X that exists in a woman to form a Y X male. So while people say it's the man who determines, it's actually a combination of the man and the female that will determine the sex of the child.
Sex of the baby, yes. All right.
Yes.
Now, there's a lot of people who ask, fine, then why is it that we have other families who only have only boys and another family that has only girls? What usually happens? And yet we have the X and the Y coming together. So why?
It's about chances.
Okay.
You see, because the probability of having a male or a female is the same. You flip a coin.
Okay.
It goes up. Sometimes it will be tails throughout. Sometimes it will be heads throughout.
Yes.
However, there are many theories that people have employed from time immemorial to try and influence the sex of the unborn baby. But ultimately, it's all about chance. So Dr. Kireti will tell you about the ovulation cycle of a female, and I will tell you about the Ys being very fast and furious in terms of the sperms which are being produced, such that when somebody basically, when a couple basically has intercourse at around the time when the woman is just about to be fertile, just about to be fertile means basically the male will produce the sperms, the Ys will exhaust themselves, and the X's will remain, such that the person who is born is a female. Around the time when the female actually has produced the eggs, the theory has it that the fast and furious, which are the Ys, will go basically and fertilize. So people play around this, but it's not very scientifically proven. No studies which have been done, but it is anecdotal. What you say, basically, people talk about this. You will hear some families talking about some diet, that if you eat this, or if you avoid alcohol for this duration of time, you are going to produce boys. So there are a lot of anecdotal things, but really not scientific. At the end of the day, this is all a game of chances, and you flip a coin, it can be a tails or a head. That's basically my understanding of it, and pretty much what it is that happens.
All right, 50-50-50. It's like a 50-50 chance. Okay, Dr. Kirek, you want to chime in on the same very quickly?
I want to throw one or two words to what Dr. Misango has said.
And can you time it? There's a lot of people who say the position, and also, again, before ovulation, after ovulation, so just tying all those things together.
Exactly as what Dr. Misango said. These are theories. In order for us to prove a theory, it means that we take, let's say, 300 women, 300 couples, and they have to be the same age, for example. They ovulate at the same time. Their husbands produce the same amount of sperm in terms of quantity, quality, everything and everything. They have to have intercourse at the same time, and then we give them time.
That's impossible.
Almost impossible to do. So if we find, for example, in group A, the ones who have intercourse a little bit earlier before the ovulation and whatever, who want to have boys, and group B, the ones who have intercourse, you know, when they want to have girls, and then group C, they just have intercourse whenever they want. A baby. And then we see in which group actually is the highest gender. So if we say, like, for example, in group A, whom we have actually removed all these what we call variables, and they actually have the highest number of boys, then we can actually say with a certain degree of, you know, certainty that if you do this, but again, you have to take into consideration your age, sperm count, and the age of the woman, and so on and so forth, which is almost impossible to do. So this is why they are just theories. Having said that, yes, we can actually determine which gender the woman is going to deliver. How do we do this? We do actually what is called gender selection. The woman can go through what we call IVF, in vitro fertilization. We stimulate her by giving her medications, injections for about 10 days or so. We collect the eggs from her. The partner gives us sperm. We create the embryos outside in the lab. And after 3 days to 5 days, we pick a few cells from these embryos, and then we send them for analysis. Let's say, for example, we have 20 embryos. Out of those 20 embryos, we'll get, for example, embryo number 1, number 3, number 5, number 7, number 9. These are X, Y, and they are okay. You remember what Dr. Misango said about not being okay, and they are okay. And then we get, let's say, embryo number 2, number 4, number 6, number 8. These are XX, and they are okay for transfer. Now, from number 10, number 11, let's say number 10, number 12, number 14, number 16, these are XY, but are not okay. And then let's say number 13, 15, 17, these are XX, but are not okay. And then let's say number 18, 19, 20, these ones we actually don't know. Then we are actually sure, 99.9% sure, that now if Lubembe wants to have a baby boy or wants to have a boy and a girl, so we will prepare her body, her womb, and then we will take from those embryos that we know, XX, which are okay, and XY, which are okay. So you want 2, okay, or you want 3, we take 2 XYs and 1 XX. We transfer them to you. And then we hope that all of them will implant. And then that one will give us 99.9% chance that you'll have the sex that you want. The only thing is that it's very expensive.
It is very expensive. It is
very expensive.
It is very, very expensive. And we hope that something will be done to make sure that, you know, at least it's a little bit affordable, you know, for every couple.
What I can say is that most of the couples that I see who actually want that, they have one gender, and actually 99% of the ones who have come to me, they have girls and they want a boy. It's only 1 or 2 who have come and said, you know what, in my house is too much energy. There are 3, 4 boys running around, and
I just want someone
we want somebody to cool this energy down. We want a girl in the mix. So yes, I mean, once they come, and usually they are prepared psychologically, and they're also prepared financially, and they want to go, you know, the full gamut as it were.
All right. Okay, Ruth, all boys, all girls, mixed. What do you have?
I have 2 boys, 2 girls.
2 boys, 2 girls. Perfect. That is really, really good. So the last one, and how old are they right now? How are they doing?
The first ones are 4 years. The second one is 2.5 now.
Okay.
Yes.
All right. All doing well?
Yeah, very well.
All right. So I'd want you to talk to, especially the ladies who are like, listen, I want to have babies, but it's a little bit difficult for me. You went through the process of miscarriage and then took a while before you conceived your babies. So we'll want you to just talk about, to the ladies who are like, this is difficult, I don't know what to do, a little bit later on. But for now, Dr. Misango, very quickly, in terms of then contraception, because remember Dr. Kireki talked about an aspect of it's important to at least do a bit of family planning, do a bit of spacing to allow your body, number one, as a woman to, you know, adjust, heal, do all those things, but also allow yourself time to bond with the baby. When it comes to contraception for the men, how can the men come in? And I'm asking that very cautiously because a lot of them are like, this is a woman's thing, all right? So when it comes to contraception, what do you have to say and what role can the men play?
The issue of male contraception has been with us for a long time. And as I said earlier on, in our society, men are judged by their ability to produce, not their inability. And we have various options of contraception available for men that are acceptable. One of them is barrier methods, or others called condoms. The others are the withdrawal method. And then we have processes that basically interfere with a man's ability to produce the sperms. Now, this is quite controversial because a lot of men have a problem here in Africa with interfering with their ability to produce sperms. This can be done either medically or by surgical means, where medically we basically make a man not produce sperms. Unfortunately, most of the things that make a man not produce sperms also make the man become impotent. In other words, they do not able to achieve an erection. And so this is basically counterproductive to the relationship because you obviously do not want to stop to have contraception by not having sex.
All right.
Then one of the things that has taken off in Europe very much is what you call basically vasectomy. It's a surgical procedure where we block the tubes the same way we block tubes in a female sometimes for her permanent contraception. Now in a male, there's a tube that carries sperms from the testis to the ejaculatory duct. So this tube is called the vas, and we can do a very small surgical procedure. Actually, it's something done in the office, and it makes a man permanently unable to bring out sperms. So they ejaculate, but we call it basically the fire blanks. Now, it's why I say it's controversial is because many people who opt for this method of contraception are the ones who believe that they no longer have a need to have children again in their life.
All right.
However, from my experience, the younger the people that choose the permanent contraception, the more we have them coming back within 3 years,
And
choosing to
they
have
want.
a reversal.
Oh, wow.
And reversal is very complicated. The chances of success is very limited, even in the best centers of the world. But however, we still try to attempt the reversal because it's a choice. So I honestly do not like doing vasectomy on young people below the ages of 40 because nearly all of them will come back.
Don't want to come back, yes, and have a baby.
Yes, and it becomes really complicated. So we offer them the other methods, which are the barriers, or the timing method, or the withdrawal method. But most of them actually, they are quite, because it's a couple, they understand each other, and they will actually be able to time, especially if the female knows which are safe days and unsafe days.
Okay. Does it really work? Very quickly, like it's like a yes or no answer, right?
Yes, it works.
It works. Okay, all right, because a lot of people say, hi, where? It does not work. Never works.
It works as long as the female knows her cycles and she actually has regular periods. Regular cycles, it works.
Okay. All right, so Ruth, very quickly, talking to this, or a couple, let's just say a couple, because you go through it, you have, you know, an experience on the same. What would you say, especially for those who are like, we're really trying, but it's not happening?
The first thing, if you get married, I think it's nowadays that there is divorce, but you know it's like something lifetime. It's somewhere you are entering to forever. So the first thing you have to ensure is that you pick a is it a husband or a wife, a spouse, who is very, very supportive. That's the first thing. You should be understanding, because these things, some of us, if we could only have an option, we could have given you that option, but some of the things are beyond our control.
All right.
So the ladies, maybe you should be encouraged, and then you accept yourself. Like there are things you cannot change, so you have to wait. So if you wait and it doesn't happen, then these people like Dr. Kireka, Dr. Misango, they can help us, because they have said there are alternatives. No woman is born infertile. No woman can die like that without a childless. There are many options which have come, which can help them become mothers.
All right.
So let us not give up. And also the society should stop stigmatizing and giving pressure to women who have not given birth. Personally, like my experience, you see like 4 years, and then people are thinking you have stayed for long.
Yeah.
And then you're like, this is just a very short time.
Yeah.
But now the society puts a lot of pressure, and then you find these people, some of them divorcing, a man marrying another wife, and such things. So let's try to remove the stigma, and then let's be supportive. You could talk to that couple, and then you might be having a solution to help them.
All right. Thank you very much, Ruth. And I know time is not on our side, so let's very quickly, like in the quickest ways, take a look at your feedback, and then we'll end the show. So let's hear what you have to say as far as the question of the day. And this one says, depends on the stage of the female, is on the menstrual cycle. Male sperms are much faster but have high mortality rate, dying after about 2 days. Female sperms live in the, I think eggs, right? Oviduct for about 5 days. So depending on when you had sex before the ovulation period begins, all right? I think they meant eggs. And then other one says it's actually the presence or absence of the Y chromosome. The X chromosome is present in both genders. And then someone else says, a lot of factors including time of ovulation, age of the man, level of testosterone, hey, the term in the man, and then family DNA, all right? And then someone else says time for both partners is a major factor, all right? And then someone else says the XX and YY chromosome, I think they meant XY chromosomes, the weaker the genes, the gender determiner, all right? And then someone else says time of ovulation. Okay, as simple as that, time of ovulation, all right? And then someone else says sex chromosomes, that is X and Y. And then someone else says it is the male who determines the gender. He carries both the X and Y chromosomes, all right? But Dr. Misango has said no, it is both the male and the female who are very important as far as determining the gender of the baby. So we have to end it here. I know this is a conversation that we could go on for like 5 hours, but again, time, all right? So let's put a pause on the conversation that is on planning for pregnancy. And tomorrow it's all about COVID-19 and the mutations and vaccinations and all the conversations surrounding COVID-19. So you do not want to miss that conversation. But for now, a very big thank you to Dr. Kireki Manwa, gynecologist and fertility specialist. Thank you very much. And Dr. Samson Misango, a urologist. Thank you very much, Daktari. And not forgetting Ruth Omanga, who is a mother of 4 amazing babies. Thank you very much for making time for us today. We'll see you tomorrow morning, same time, same place. And of course, a special thank you to a very big team behind us who put together and ensured that the show is a success. Enjoy your day, and I'll see you tomorrow. Thank you.